Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
So good morning. Thank you for joining me, Professor Robert Newton. It's a true pleasure to be here with you today. My name is Catarina Ribeiro. I'm a board-certified medical oncologist. I work as a medical director at the big CRO, but I have this personal and academic interest on the field of exercise and lifestyle oncology in general. So for me, it's really an honor to be here discussing this with you. So would you please tell us a bit more about yourself? You are obviously professor of exercise medicine at Edith Cowan University in Australia. You've published in uncountable publications in this field of oncology and joined the guidelines. You do training for different for professionals of different areas. So tell me a bit more about you, your path, and what brought you to this field of exercise in oncology.
Oh, certainly, Katerina, and thanks for the opportunity, for the invitation to come and be on your podcast. It's great. I started in exercise science in 1980, so I'm 45 years into the field. The first 25 years were, I was focused predominantly on the underlying mechanisms around human performance. So a lot of the physiology, endocrinology, immunology of how the human actually responds and adapts to physical training, physical exercise. And this was mainly directed at high performance. So athletes, warfighters or soldiers, and those, those sort of aspects where it was looking to how do you actually optimize the capabilities of the human machine. But around 1994, hard to do the math, so that's 30 years ago, I was at Penn State doing my postdoc, and Penn State University, obviously in the US, and I ran a study there in elderly men. So these were old men, and it was a very mechanistic study trying to see if and how they could increase their maximal power output. So beyond strength, but more their actual explosiveness. So vertical jump is a probably good example of that. And it was people thought that was a bit outrageous to have old men jumping, and they were jumping with weights on their backs. But you saw some beautiful improvements in power, strength, capabilities as well. So that was my sort of foray out of athletics and tactical research into more into the clinical side, I guess, of things. I was then I worked in the US I came back to Australia after my postdoc. I was then offered a position in Indiana at Ball State University, which is a very, very famous human performance laboratory. And there again, they had a very large research and clinical program and a community engagement program around healthy aging. And thousands of members of the local community would come onto campus every day, and they would do various physical activity, sport. They would receive information on diet and more healthy lifestyle, if you like. Mm-hmm. And so that sort of reinforced my interest in this field. And then in 2002, I was asked to apply for a professorial chair position back in Australia. Not many of those available, so I applied for it and tried my best. And the pitch that I put to the university, Edith Cowan University, which I still work there now, some 22 years later, and my pitch was that I wish to apply exercise as a medicine for people with cancer. Now, the driver for that was that in the meantime, my father was diagnosed with prostate cancer. He underwent a prostatectomy and then 6 weeks of radiation therapy. And he came back from that with urinary incontinence and overwhelming fatigue. And he just found it difficult to do anything, and his quality of life really declined. And he kept asking his urologist in this case, look, what can I do? I'm just tired all the time. And the urologist, as you mentioned earlier, the urologist just said, just rest. You have to rest to get over this. You're tired. You have this fatigue. You have to recover. You have to get do rest. And so he just sat all day. And as an exercise scientist, I said that this can't be right. I just saw his muscles get smaller and him get weaker and the fatigue get worse. And I said, come on, Dad, let's go for a walk. Yeah, let's just walk around the garden. No, no, no. The doctor told me to rest to get over this fatigue. And I went, this can't be right. I even suggested doing some weights. Look in your chair, Dad. Would you do some weight training? No, no. The doctor told me to rest. Well, 2 years later, he died of a stroke. So of course, because when you just sit all the time, all the other chronic diseases just accelerate. So to be honest, if he would have been left alone, hadn't had any of the prostate cancer treatments, he may or may not have lived longer, but he certainly would have had quality of life, which he didn't over the last 2 years. Now, this is not a fault or a criticism of the care team that he had at the time, because the knowledge at that time was if you have cancer-related fatigue, you need to rest. But we didn't know back then the cause of the fatigue. And people just assumed it was the same causes as happen when you spend all day gardening or you have a really long day at work where you're concentrating, you're doing your work, and at the end of the day, you're tired. But it's not. It's entirely different mechanisms to that. And it was that experience that drove me to commence research in exercise and cancer. Specifically, I started out looking at prostate cancer, the treatments and how to manage the side effects of that. Well, it must have been a good idea because the university offered me the position, and I started there as the professor of exercise medicine. And as I say, I'm still here some 22 years later, still at ECU, which is a fantastic university. And that's provided me with the environment and the support to be able to really grow our research field. And and I mean, now I think we're more than 250 journal publications later, and hundreds of conference presentations, and as you say, position statements that we've contributed to, and quite not boasting, but as I guess as mild as I can put it, I think that our work has changed the way in which patients and clinicians view exercise as a medicine for their cancer. And, our team's very proud of that.
Yeah, indeed. And it's really curious that you share this personal story and as part of what brought you to this field. So you saw some, say, empirical observations and something that was counterintuitive for you from your background training. And
Yes.
we see this quite often in research and things that change like the practice. It comes from our own experience and connecting to different areas that haven't yet been connected, let's say.
Yes.
Something that I find really interesting about your research publications and areas is that you've also been going back to finding the mechanisms and looking at in vitro research. So I was wondering if you could also tell us a bit more about the research that you conducted on tumor cells. So you've analyzed the effect of post-exercise serum on tumor cells and
Yes.
showed some reduced tumor growth. Can you, just tell us a bit more
Sure.
about that?
Despite all the evidence, exercise medicine is not offered to all cancer patients as standard care. Despite overwhelming evidence from the last 30 years that the outcomes for the patient will be better, that their quality of life, which is the main thing, will actually be better. Symptom experience will be reduced. Side effects of treatment will be much lower if the patient is physically active or gets physically active. The problem is that it hasn't been adopted broadly, and most patients have no access. They can't access exercise oncology services. Government doesn't really support it. Health insurance doesn't support it. You can't provide a service without funding. It's you have to pay the staff that are delivering the exercise oncology. They have to eat like anyone else. They have to feed their kids and put them through school. So you can't have, a quality service that's free. Someone has to pay for it. But for some reason, there's just not the desire through government, health insurance, hospitals, cancer centers. There just is not sufficient motivation for them to implement broadly high quality exercise oncology services. And so I think a part of this is people think, oh, it's just physical activity. It shouldn't cost anything. Just tell them to walk. Why should you have to pay for, exercise? It's free. And don't get me wrong, any physical activity is going to be beneficial for the patient. The worst thing they can do is be sedentary, and that really compromise their capacity to overcome the disease and survive. But I think we could do a lot better than that. Particularly patients who have advanced disease or have very aggressive disease, patients who are going through treatment and experiencing quite impactful toxicities or side effects of treatment. We have to do better than just tell them to go out and walk or join a gym. That doesn't work. It just doesn't work. They won't, or they can't do it. And so we have to be much more sophisticated than that. And that's why we've been really looking, well, how else can we motivate patients and clinicians and government and insurance companies to actually support exercise as a medicine rather than just generic physical activity guidelines? I mean, we provide, when we run our randomized controlled trials, we provide to the control group, so those patients which are randomly allocated to the control group, we give them the American College of Sports Medicine guidelines for exercise for people with cancer, because we know it won't help them. They won't change their behavior because they have no support to change their behavior. And so it is a very effective control condition. We can even give them advice. We can give them a walking program and say, look, if walking's really good, which it is to a certain extent, depending on the patient. And we know that is still, if you like, a placebo. It is a sham exercise because they either won't do it or the exercise is so low fidelity, so low in quality and in effectiveness that it doesn't make any difference for them. And so we can contrast that with what we actually test as the intervention, which is a very high fidelity, supervised, supported exercise program, to allow us to have a look at how is their physiology shifting that makes their environment more cancer suppressive. So I am leading into why we do these cell line studies. So we then did a lot of work, many studies where we looked at improvement in quality of life. And again, it's clear in randomized controlled trials, we show that we can vastly improve the quality of life of these patients. But that's not sufficient, because if anyone exercises, whether they've got cancer or not, their quality of life improves. So it's a bit like, well, why did you do that? What's the point? Of course their quality of life improved. What, you thought it'd get worse? And so that's not convincing. Although, again, quality of life is, as you know, is probably the #1 priority for the clinician and for the patient. Even in many cases, more so than actual survival. So they then said, well, exercise is all the same. It doesn't matter what they do. So that's why we've delved into these studies, and we're now doing head-to-head studies where we compare different modes, the two major types of exercise being aerobic versus resistance exercise, because we don't even know which works best. We don't even know how they work. So it's a bit like, oh, gee, do we give the patient chemo or radiation therapy? Oh, we don't know, so let's give them both. I mean, you couldn't imagine in the oncology setting for the clinicians to sit around and say, we don't know how it works, we don't know which one to choose, so let's just throw all of them at the patient. It wouldn't happen. You'd make the patient really unwell. Fortunately, it doesnn't matter too much if we throw everything at the patient at once. It's not optimal by far, but it doesn't cause, huge amount. Well, it doesn't cause any side effects, to be truthful. It just may not be as effective as it could be. So that's why we do these studies where we exercise the patients, we take their blood pre and then post the intervention. We examine the chemical makeup of that blood, particularly looking at some peptide molecules which are called cytokines. And these cytokines are released from the muscle tissue. And they're called myokines when they're released from the muscle tissue. And these myokines have been demonstrated in vitro. So if you take a living cancer cells and you just pour these myokines individually over the cancer cells, they actually suppress their growth. They actually cause cell death. In different ways. Each one has different mechanisms in how it works. Some damage the DNA, or not damage the DNA, but they signal the cell to go through apoptosis or programmed cell death. Others signal to slow the rate of division, and so growth. What we see when we exercise the human is these myokines accelerate in concentration in the blood, even at rest. So they're much higher after, say, a 3 or a 6 month period of training. So that's why we do these cell studies, because without that, we can't really prescribe exercise optimally, because we're not quite sure, what works. I mean, what gives the best myokine response? What gives the best? Because the key side to it is that these myokines signal to the immune system, and they activate and make the surveillance capability of natural killer cells and T cells more effective. So they become better hunter killers, if you like, under the influence of these myokines. And the other role for the myokines is that they help to modulate or offset the signaling molecules which are released from fat tissue. So from adipose tissue, they're called adipokines. They have a lot of pro-inflammatory signaling, and they tend to create a more cancer-promoting environment or supportive environment for the cancer cells. And that's a key role, again, for the myokines, because they help to modulate that. So that's why we're looking at these adipokines and myokines. We are looking extensively at the type of immune cells being produced by the patient and how active those immune cells are. And the main purpose then is to understand the mechanisms by which this observed better survival. We know that there's an association between being more physically active and survival. In some cancers, it's as much as 50 to 60%, which is enormous. But the problem we've always had is that we don't know if it's a reverse causality. We don't know that those patients that are doing better, perhaps a little bit healthier, don't have as much disease burden, they exercise more because they feel better, but they also survive better because they're not as unwell. So it could be the reverse causality. It's not a direct causal effect that we can see. And so that's why these studies are important, to see if it's trying to understand how exercise actually causes the suppression of the growth of the tumor. How does it suppress the tendency of certain cancer cells to metastasize away from the primary site? Now, of course, everything's changed markedly as of 3 or 4 weeks ago. The first prospective study was published in the New England Journal of Medicine, arguably one of the top medical journals on the planet. And what they showed was, in a randomized control trial comparing an exercise intervention with usual care, they demonstrated the exercise to actually extend survival around 37%. So this was groundbreaking. It was also presented at the American College of American Society of Clinical Oncology. Sorry, I've been to many conferences of late. I have trouble keeping track of them all. And it was presented there and absolutely amazed the people that were in the audience. And a particular slide was shown that indicating that demonstrating that the survival benefit was equal to or better than some of the key chemotherapy agents, which is quite astounding. Just remembering that exercise is not a cure for cancer. Exercise will never cure cancer. There's no mechanism by which exercise could cure cancer. Obviously, chemotherapy, radiation therapy, surgery, immunotherapy can be curative. But it was interesting that in terms of survival, this particular exercise intervention produced the same benefit as some leading chemotherapy agents. So that's changed the field entirely, and I think the interest in exercise oncology has exploded. People are reaching out to our team, to other teams around the world, as to how can we implement this, and I guess that's now the challenge: is how do we broadly implement exercise oncology into routine patient care, because now it's been established as a first-line treatment. It's not an associative or adjunct treatment. It's now a first-line treatment. It's been established through this particular challenge trial, which was led by Kerry Cornier, an outstanding scientist based in Alberta, Canada.
Yeah, it is wonderful to see what's happening since the publication of the challenge trial, because I think that for most of us already familiar with the field of exercise in oncology, even through observational studies and what we've been understanding about the physiology and the role of muscle as an endocrine and immune organ, as well as you were discussing, we already knew it was really important. But what this trial brought is very specific numbers and graphs as well, but on the language that we usually speak in oncology. So we look at prospective, big, randomized clinical trials, especially published on New England. It's something that clinicians cannot look aside, right? So it's
it's pretty hard to ignore. Yes. Absolutely.
And it's getting lots of media attention as well, which is amazing.
Yes.
It's really a very nice way to echo the message and cascade it through different settings. But this also leads to something that I was thinking while you were explaining what you've been doing and why you've been going to these in vitro models. And one of the challenges that we have in research with exercise and lifestyle interventions in general that are very complex is that we still need to follow the research methods of evidence-based medicine. So we have the different phase clinical trials, and we have the preclinical research, which would touch on the mechanistics and in vitro models that you were discussing. So it's really nice that you went there or that you have this focus to understand the mechanisms. But something that we still don't see often in oncology, in exercise in oncology, is the phase ones. And obviously there are reasons for this, because it's not so easy to tailor doses as it is for drugs. But how do you see the role of this, like phase 1, phase 2, and then the phase 3 clinical trials for exercise in terms of dose, intensity, frequency?
Yeah, that's the challenge we face now. We don't know which exercise is most effective to create an anti-cancer environment. We can hypothesize on it. We did one of our studies with men with prostate cancer. What we showed was that there was an association between the increase in muscle mass and the increase in resting levels of certain myokines. So clearly, having low muscle, that helps to explain why having low muscle mass is a highly prognostic factor for bad outcome. So we sort of starting to understand that that certain interventions or certain modes of exercise are going to be necessary to certain patients, and that's why we have to move to a tailored or precision exercise oncology model. I think one of the advantages we have with exercise is that it doesn't have any side effects. So, in a dose escalation study, you're looking for when do toxicities overwhelm the patient. You don't have that issue with exercise. You'd have to give an enormous amount of exercise, which would be unrealistic. You wouldn't do it to actually not cause any side effects. But Lee Jones did a very nice study where he had women with stage 4 breast cancer doing a fair amount of aerobic exercise, and whilst what they reported was no benefit in terms of fatigue, and also there was some blunted response or adaptation in terms of their aerobic fitness. So it appeared that at a certain level, these patients with a lot of disease and symptoms and treatment side effects were just not able to respond and adapt. So there is an upper limit, but within normal exercise prescription levels, no, it's not. But so we can use our knowledge of exercise science, because that knowledge base is enormous. We've been studying human performance and exercise responses for thousands of years, to be honest. When you think about the research that was done through the First and Second World War, through the space race, and now in modern pro sport, I mean, our knowledge of the human and how it responds to different types of exercise, different dosages of exercise, is exceptionally well known. It doesn't get implemented in the clinical setting terribly well, but those dose escalation studies have been done extensively in healthy people, and many of the same mechanisms and findings translate to a person with cancer. The studies are hard to do. Exercise studies are exceptionally difficult to do, exceptionally expensive. We have the issue of how do you have a true control? That's very hard to do. People that volunteer for an exercise study, or clinicians that refer their patients to an exercise study, are very unhappy if they end up in the control group for good reason. It's all over the media that exercise is good for you. And then we say, no, we just want you to keep your sedentary lifestyle. So they either refuse to participate, and that creates a bias in your study, or they exercise on their own and don't tell you about it. So it contaminates the study. So it's very difficult. It's not like a study in a new immunotherapy drug where you can have a true placebo group. So those studies are hard to do. I think that rather than wait for those trials, I think we have to again fall back on the extensive knowledge of how the human responds to acute and longitudinal training exercise, and then draw on that. What we've done in Australia in terms of the position stand or guidelines is that we've moved from a generic model. So the generic recommendation in most countries of the world and the World Health Organization is 75 to 150 minutes of aerobic exercise and 2 or more resistance training sessions per week. That's the same recommendation for healthy adults. So clinicians get a little bit confused by that, and I don't blame them. They say, well, hang on, why is it the same for a cancer patient? In the main, with the patients that we work with, they can never achieve that. It's unrealistic. And so we look at, again, we come back to more precision exercise oncology. We do extensive assessment of the patient. We determine those aspects in which they're most deficit or is causing the greatest risk for morbidity or mortality. And then we design a highly precision exercise program to target those aspects. That's probably where we need to go. And I'm not so sure that we need to wait until we get more of these phase 2, phase 3 trials. We can't wait. We've got patients that have, need exercise medicine now.
I agree, but it is a challenge with the control arms. I've been facing the same when I was planning the trial that I'm doing for the PhD. Like, is it ethical at all to just offer a control or an information leaflet, or how are patients gonna respond to that? So you cannot really blind an exercise intervention, and even if you offer something so suboptimal, so less structured, like walks or Pilates or some sort of light form of exercise, it's not really like a in-heart control. So yeah.
No, it's not. So I mean, we do head-to-head comparisons now. So we're doing trials now where we're comparing aerobic high intensity interval training and resistance training, and in a head-to-head comparison without any true control group. And in the past we have done actual trials where the control group, if you like, receives not a sham exercise, but the exercise doesn't influence the parameter that we want to look at, the quality that we want to look at. So if we really wish to look at changes in muscle mass and quality, we might use Pilates or yoga as a control condition, because those exercise modes, whilst very helpful, they don't actually change the outcome that we're trying to examine, and we can then do controlled studies that way.
Yeah, sounds good. And so one of the questions that most people have in mind when we think of exercise, and say clinicians or patients, so what is the right type of exercise? Like, is it strength training, aerobic training? Is it a combination? None, neither of this.
For most patients, it will be a combination, but the emphasis will vary depending on their specific issues that they have and morbidity and mortality risk that they experience. So, as I say, in our clinical practice, we've moved to a precision exercise oncology model. We assess the patient extensively, and then we design the exercise prescription based on that. The other thing, as you've well experienced, is these patients don't have a lot of time. They've got a lot going on in life. Many will be still working, many will be caring for elderly parents or even caring for children. They have their appointments that they have to go to for chemo or to their doctor. And so they're very time poor in the main. So we have to come up with highly efficient exercise prescriptions that are easily accessible. And so, I've spent a lot of time, particularly since COVID. During COVID, of course, we were not able to provide face-to-face exercise supervision for our patients, and we had thousands of patients either on trial or as patients within our clinical service. And we had to pivot very quickly to telemedicine. And look, we did it, and it was pretty clunky, I must admit. And if you remember, Teams didn't work very well, and Zoom Zoom would work sometimes, or the particularly over poor internet, it wouldn't work. But that's all changed. We're having a great conversation now with no problems. But the internet infrastructure obviously accelerated enormously over COVID, because they had to, the world's governments and companies had to quickly improve the internet. Cellular networks were improved markedly as a result of COVID, because we had to ramp up communications, because people couldn't meet face to face. You couldn't do business. You couldn't do healthcare, because face to face for many services was out in the health system, unless certainly in Australia, unless you needed critical care. They said, don't come to the hospital, whatever you do, stay away. So through that experience, we developed a lot of technologies and techniques to provide high quality exercise to the patient. I think a new mantra as well with patient care is they should receive their support at a time and place of their choosing. At the moment, in the past, what we've said, you have to be at this hospital at this time. And there's a lot of barriers. If they're coming for chemo, it's one thing, because they go, well, I have to have it. And so they'll put up with a lot. But if it's just to come for exercise medicine, even though the exercise, in my opinion, is equally as important as the chemotherapy infusion, it is something that they still consider, and clinicians still consider to be a nice to have rather than a must have. So if access, distance to travel, cost of parking, difficulty in finding parking, everything, all the barriers that hospitals and cancer centres have, then they won't adhere to the program. They say, I can't do it. I'll just drop the exercise out. So we have to look at ways. And so we've been, I've been involved with a company to really enhance that ability to deliver. There's many other companies working on biometric devices. I've got an Apple Watch, but there's many other examples there where we're using sensors for heart rate variability, sleep quality, movement, steps, etc., glucose, a whole range of other things, to be able to do a lot of the assessment and then deliver the actual interventions remotely. That's where the future is, because it's the only way to scale up. So I'll tell a little anecdote. Many years ago, you have to be at least 20 years ago, when I first set up our exercise clinic, and we had many predominantly cancer patients, but we see anyone with a chronic disease, but most were cancer patients. And the research director for the Cancer Council for Western Australia came out to visit, because we invited him. Have a look what we're doing. And he said, this is fantastic, absolutely fantastic to see all these people doing their exercise and, various stages of their cancer and treatment. And he said, wow, this is fantastic, Rob. Like, how many patients could you support in a year? And I said, look, easy 600. We could probably build it out to 900. And he said, Rob, that's a problem. We have 12,000 new cancer diagnoses in Western Australia each year. Now, clearly, it's gone up markedly by that. Since then, it's probably 20,000 a year by now. Which, that is the challenge. Is it will never work to be able to actually provide, particularly exercise medicine, only in cancer centres, only in hospitals. There's just not the capacity. So that's why we've worked really hard on our platform. So we have a patient care platform, and to be able to, anyone can access it anywhere in the world to get this support. I think also along with that is what we saw during COVID. We did a lot of questionnaires and focus groups, and we said, look, how did you like exercising at home? And they said, yeah, it was okay. I'd rather be in the exercise clinic, but it was okay. And then we said, well, what were the main barriers to you exercising at home? And the number one barrier was their fear that something would go wrong. Their fear that they didn't have an exercise physiologist sitting in front of them, watching them, and they were worried that they might hurt themselves, hurt their back, or that they'd have a heart attack or whatever. Now, even in the home, exercising, the risk of an adverse event is exceptionally low. It's very, very low, even for someone with cancer. But this was a major concern. This is what they listed, number one. So that was a barrier. And so again, we've been working very hard to see how we can actually monitor them remotely. And that's, with the current technologies, that's possible, absolutely.
Yeah, even EKGs or even more advanced.
Yeah, we can get a very, very high quality EKG. And there's a company in Perth which has put together a very nice system. It's inexpensive, and you can get a beautiful EKG, electrocardiogram that you can then, the EP, the exercise physiologist, can check. And if there's any issues, then they can just send the signal or send the data to the cardiologist, and then the cardiologist can review and then make a determination whether the patient needs more workup or whether they can just continue with the exercise. So all of that's available now.
Yeah, definitely technology and these online environments of platforms open up an infinite possibility of like scaling the interventions. But how do you see like the tailoring and personalization of the exercise programs and assessments with this like scalable platforms?
The other huge barrier is that we don't have enough health professionals that are trained specifically in exercise oncology. I teach a lot of the exercise oncology in our undergraduate degree for exercise physiologists. The content's fairly minimal because they have to do cardiac, they have to do respiratory, they have to do renal, they have to do neuromuscular, musculoskeletal, all of these different conditions they have to cover in their degree. And so they get minimum content around exercise for people with cancer. And so they do lack confidence in working with people with cancer. Physiotherapists is another allied health professional that could fill a lot of this void. In the main, in most countries, they do not receive much training in exercise physiology. They don't receive much training in immunology, bit of pathophysiology, but not a lot, because physiotherapists are brilliant at, neuromuscular issues, musculoskeletal, fantastic. So within their degrees, there's no room, just go in depth into immunology. Exercise immunology is it's an intense area to say the least. And then you have to have a solid understanding of endocrinology, because this is critical in the prescription of exercise for people with cancer. And so physiotherapists again are trying to help these people, but they're saying, look, I don't have much of a background in training science. I don't have much of a background in exercise physiology. And for these patients with cancer, I mean, it requires a systemic approach. The issues that they're facing is is not isolated to a shoulder or a knee or a hip. It's systemic, and so it's an entirely different skill set and knowledge base that's required for it. You'd never have a radiation oncologist having a shot at prescribing chemotherapy. It just wouldn't happen. And by the same token, I don't think we should have medical oncologists planning out the radiation course for the patient. And so we have to address this skills gap within the professions, and we're working on this very heavily. I had the opportunity last weekend to deliver a course for FitMed. FitMed's an Australian company, and we delivered that in London. It was very well attended, and we had physiotherapists, exercise physiologists, and personal trainers. I see an enormous capacity in terms of personal trainers. The number of personal trainers in the various countries far exceed the number of physiotherapists or clinical exercise physiologists. I get a little bit of pushback with people saying, "Oh, should we have send our cancer patients to be looked after by a personal trainer that's perhaps done a level 4, which is the equivalent of the first year of university?" Exercise physiologists are a minimum of 4-year trained, university trained. Physios are the same. I can understand that hesitance, but I think that in a multidisciplinary team care arrangement, I think we can get it to work. I think that the clinical exercise physiologist should be doing the initial workup with the patient, determining their fitness capabilities, the key risks for them around exercise, whether it be cardiovascular or whether it be in terms of muscle content or whatever. And then they can do the initial prescription. But once the patient is going along okay and they're coping with the exercise, then I see no reason why they can't refer to a personal trainer, which is often closer to the patient's home and more accessible. But keeping open, obviously, a clear communications channel so that if anything comes up, you can go straight back to the clinical exercise physiologist and say, I need some help here, I need some advice. And in some instances, if the patient does have issues, they may have to cycle back up under the care of the clinical exercise physiologist. Obviously, if any care health issues arise, then they're going to have to be back with their oncologist or their general practitioner. But it's that model. Even if the personal trainers are only supporting those patients that have relatively few issues, they don't have bone mets, for example. Bone mets is an exceptionally complex condition to manage in the exercise setting. Perhaps that personal trainers may not work with these patients, for example. But patients without bone mets, with relatively stable disease, or certainly cancer survivors, then they could be supported by personal trainers and fitness instructors, so long as we had a good care arrangement in place, and the PT or fitness instructor was just part of the care team, along with the medical oncologist and the GP and the exercise physiologist or physio.
Yeah, so if I understand correctly, you're suggesting a model where we would have like the exercise physiologists or the physiotherapists making like a triage or a first assessment, and then they would triage the patients that were, say, low risk.
Yeah.
And is there any algorithm that you had in mind that could help with this triage, like the ACSM, or any more specific triage tool that we could have like scoring these patients?
Yeah, sure. I think that probably I don't want to push our own paper and our own national guidelines, but I think the guidelines in the Exercise Sports Science Australia guideline, and look, I got to declare a conflict of interest. I was an author on that, but we laid out a fairly clear triage pathway for how that could happen. Look, the American College of Sports Medicine too does have some very nice documents around how patients can be triaged out, in particular their pathway to support by a fitness professional rather than an allied health professional. I think that's quite a good example as well. Absolutely.
Yeah, thanks for sharing. I'm sure this is a very interesting resource also for whoever may be listening to us.
Yeah.
And also, we were touching on the different components of exercise. Um, you have a publication on alternative types of resistance training, let's say, and their
Yes.
potential for oncology. I know that many of them are not so well researched, but I was really curious to hear your thoughts on like restricted blood flow
Sure.
training, for example. It's something that seems appealing as it wouldn't require so much effort from the patient. Of course, it has potential complications, as we know from the terms of
Sure.
the point of view of thrombosis or um, what we know that are the common side effects of treatments. But what are your thoughts on those alternative modalities?
Um, Look, that's a really good question, and I'll try to keep my answer short. One of the key issues I think we're seeing with patients is that this loss of muscle mass is a major problem. People are becoming sarcopenic at a low muscle mass at a younger and younger age, simply because the modern human is not very physically active, and they don't lift heavy things and they don't do much exertion. They might do a bit of walking as exercise, but again, as humans, our body, our physiology expects us to actually lift heavy things and carry heavy things, most if not every day, because of course we've evolved over millions of years, and certainly our underlying genetic expression has not changed in the last 45,000 years. So if you think what Homo sapiens, humans, were performing 45,000 years ago, is that they were lifting heavy things and they were carrying heavy things. And this satisfied the requirements of their physiology. In the modern world, we've removed that. And so we're flying in the face of the underlying needs of our physiology. And that's the reason why we have the chronic disease burden that we now have. Chronic diseases are diseases we don't have to have. They're actually a choice, a lifestyle choice. Unfortunately, one of the key issues is this low muscle mass. And so we have people coming who have low muscle mass. They then get a cancer diagnosis. There's a very close association between low muscle mass and early mortality. Very close correlation between low muscle mass and poor treatment tolerance, particularly chemotherapy. The toxicities from chemo are much worse in patients with low muscle mass. And so this problem is getting worse and worse. And so we have to turn that around. So a lot of our emphasis is on how to actually maintain or increase muscle mass in these patients. And, we can get much more effective through some of the techniques we've been trying and we've sort of listed in that paper. So blood flow restriction is just where you put a compression over the top of the limb there, slows the blood return. You get a more lactic acid building up in the muscle. You have a bit more of a hypertrophic drive at the muscle cellular level. And so, better muscle growth stimulus. It's not overly pleasant. So, it's not for all, but we have to look at ways in which we can enhance the muscle hypertrophy, create a more anabolic environment. We're having a lot of success with accentuated eccentric training. And that, again, it's been known from decades, probably hundreds of years, that eccentric training, the lowering phase of the lift, has a very strong stimulus to muscle growth. Bodybuilders use it extensively, powerlifters, any strength athlete. So we're doing that a lot with patients. The eccentric phase also doesn't require as much energy. So we're finding it quite useful for patients with cancer-related fatigue, for example. So that's why, we put that paper out just to discuss a few potential areas for research and what we're currently doing clinically as well. In the main, muscle hypertrophy is driven by volume load, which is the total number of kilos lifted in a session. And for novice, that's around 2,000 to 6,000 kilograms lifted per session. So we're focusing really on how do we maximize that, really give that stimulus. We're also looking at microdosing, and so the patient may split their resistance training volume into 2 or 3 sessions per day. So they might do legs in the morning, upper body in the afternoon, for example. It's a bit easier to fit in time. and it's still provides a really strong stimulus to muscle growth.
You were touching on sarcopenia, and definitely this is probably one of the areas where we started having more evidence, more retrospective and observational, of course. But
Sure.
in oncology, we have this huge data sets of the CT scans that patients already do routinely that we are not looking, that we are kind of wasting in terms of assessing the muscle mass. But it's really interesting to see that we have more and more publications looking at this data retrospectively and finding very interesting associations. But it's also curious to see that we've had studies with certain drugs that could increase lean body mass and could increase weight, but had no impact on survival. And one of the reasons may also be because we are not giving the functional stimulus to the muscle, right? We are probably not having such an impact on the endocrine part or the cytokines or myokine release that we can achieve through these exercises, as you were mentioning.
Yeah, I mean, we also have to note that the use of drugs to try and stimulate growth of muscle, the effects of that are very small compared to the effects that are driven by strength training, resistance training, probably by a factor of 10. So, we're giving them drugs, and of course, all drugs, exogenous drugs, not talking about internal drugs that are produced from exercise, the endogenous medicine, but all exogenous drugs have side effects. The drugs that are given to try and stimulate muscle growth, they have side effects. And then you weigh up how much additional muscle mass is accumulated versus just having the person do a quality resistance training program. It's a order of magnitude of difference. I think too, what you point out is it doesn't seem to impact their survival. So in many ways, the muscle tissue that's been accumulating is either of low quality or it is of low function. It's not proving their physical performance terribly much. They don't move any more than they would have, so they're not getting the benefits of reduced sedentary time. That muscle is obviously not producing the myokines and the other hormones that muscle developed normally, naturally, through exercise. So I think another good example is the use of bisphosphonates to treat osteoporosis. Yes, it causes accumulation of bone mass, but the bone mass is not functional. It just lays it down wherever. And, and quite often it doesn't actually increase the architectural strength of the bone. And then you've got all the side effects of, jaw necrosis and other things like that. Whereas, a targeted exercise program using perhaps resistance training and impact exercise would produce the same benefits in terms of increased bone density, but also that's highly architecturally strong, the bone, because it lays it down in the areas of greatest stress and strain. So there's definitely place for these pharmaceutical interventions, but again, it's safer and more effective to actually use exercise as a medicine. The difficulty they say is, well, you can't get the patient to do it. Well, the patient doesn't do it because they're not supported to do it. They don't get any, they don't get any financial support to do it. They can't access the professionals. The professionals they can access feel that they don't have the sufficient training to support the patients around their exercise medicine program. So it's that's the difference when it's just the way it is. The way it is. Governments are willing to throw a lot of money at pharmaceutical support, even though some of these pharmaceuticals work in 10% of patients and don't work in the other 90%. Exercise works in all patients, regardless.
Yeah.
But I'm not bagging the pharmaceutical industry. It's absolutely crucial. But again, exercise is a first line treatment for cancer, and it needs to be used in tandem with these other drugs. We may see the day when chemotherapy is an adjunct to exercise medicine. Who knows?
Who knows? But yeah, I think that one of the pitfalls when speaking about drugs is that if we are looking at drugs to try to replace like the basis of we need to cover with lifestyle, then we'll probably run short of a significant impact, which seems to be the case with these ones. But also, some of these drugs that we are exploring also target certain pathways that we know that influence cancer growth, like the HMB and mTOR. And we are not always analyzing like the tumors genomics, so NGS, or sequencing the tumors when we are testing these drugs for the purpose of body mass or weight. And this is one of the concerns that I also have. Hopefully we'll have more visibility on this in the future. You were also touching on the bone health. I think that we are more and more aware of what sarcopenia means as a clinical entity in cancer. We know that exercise, specifically resistance training, is a fundamental part of treatment. But we don't often see this, or so often, for bone, say osteoporosis or osteopenia. And when we do, I think we more often see like exercise being recommended, as you were saying, as suboptimal interventions, like go for walks, or even low impact or no impact, like hydrogymnastics. So how do you see the role of exercise for bone health for cancer patients, say patients that go through hormone therapy? We know this is one of the major side effects. What are the main exercise components that we need to implement for these patients for bone health as well?
Well, certainly resistance training, and that's been shown to be exceptionally effective in menopausal women, but also in patients undergoing hormone therapy. So our early work was in men on ADT, androgen deprivation therapy. So the removal of testosterone from the cells of the body, is fantastic for slowing the progression of hormone-sensitive prostate cancer, but it's devastating for every other tissue in the body, including the brain. And so the skeleton requires testosterone to be healthy and be maintain bone density and have the structural integrity to avoid fracture. But we're seeing these men rapidly become osteopenic and then going to full-blown osteoporosis. And if they fall and fracture a hip, the androgen deprivation also causes weakness of the muscles and frailty, so they're more likely to fall. And when they do fall, because they've got osteoporosis, they're more likely to fracture. As you know, if they fracture a hip, statistics are that they won't survive 6 months. They'll never come back from it. So we have to come up with ways to slow that. Now, interestingly, we tested heavy resistance training in these men and found it could not prevent bone loss. Now, that same program, that same exercise medicine, if that was given to, say, a menopausal woman with osteoporosis, it would totally reverse the osteoporosis. But with these men that have testosterone, they're castrate, it's not sufficient. It's the wrong medicine, if you like. We had another group that did the same resistance training program, but they also did impact loading, where they did very highly specific exercise prescription involving things like heel drops and marching on the spot, stamping the feet, progressing to some hops and jumps and things. So it was quite sophisticated and had to be managed very carefully because these are old men. We had a lead-in phase of perhaps 1 to 3 months of heavy resistance training to get them strong enough and their tissues resilient enough before we started to introduce the impact loading. And then we monitor them very carefully for any signs of pain or discomfort. Then we progress or regress the exercise prescription accordingly. But we're able to prevent the bone loss. So again, it's applying the right exercise medicine. We need to look, lifestyle is really important, but we need to stop talking about exercise medicine as a lifestyle. It's not, it's a medicine. And as soon as you start talking about it as a lifestyle, then it becomes a nice to do, not a have to do. But yeah, look, going and playing golf or walking the dog or doing line dancing, that's lifestyle and it's great and it's really good for the patient. But exercise medicine to treat your cancer may not be pleasant. It might be hard. It's likely to be hard. You're going to have to lift heavy weights. You're going to have to do high intensity aerobic exercise to create the internal medicines and the structural changes that we need to help you survive. And say it may not be fun. Well, chemotherapy is not fun. radiation therapy and surgery is definitely not fun. So we have to change the narrative here and approach targeted exercise medicine as a treatment, as we would chemotherapy. Try to make it as least unpleasant as we possibly can, but realizing for the patient, their education is that it's something they have to do, and they may find it difficult.
Yeah, I couldn't agree more, and I'm guilty of using that term. So I always refer to lifestyle oncology and exercise within this package, more like thinking of the things that we do, the pillars that we use in lifestyle medicine. But I totally agree that we need to change how we view this. So not a nice to have, but a must to have as part of therapy plans and in first line. I love how you phrase it. So the other thing I would love to hear from you, so we've discussed a bit about the barriers of integrating exercise into routine oncology care. But where do you see are the biggest barriers? Is it like system level? Is it clinician related? Is it the patient that's not so well informed?
Oh, Katarina, it's at all levels. I think the one that we're working really hard to address is the workforce capacity. So we really need to address that. I think universities need to produce more physiotherapists and probably more appropriately clinical exercise physiologists need to produce more that have a solid grounding in exercise oncology. And that's important. I think we need to upskill other allied health and fitness professionals. So personal trainers and fitness instructors need to be have the access to courses where they can upskill to be able to work with these patients where appropriate. We in Australia, we've had great success in upskilling our nurses. So we have cancer specialist nurses, and we provide them with training in exercise medicine, nutrition, psychosocial aspects. Look, we don't make them a psychologist, but we give them enough understanding of the specifics of psychology and sociology around the cancer journey that they can give some basic support to the patient and then triage them if necessary to see a psycho-oncologist. The same thing with the exercise. They give the patient basic exercise knowledge. And, you go, do you feel comfortable? Do you go to a gym? Oh, I used to, but I quit. Well, would you consider going back? And if the patient, there's no morbidities that would preclude that, then yeah, they can go back and start again at the fitness center or continue on. Some patients come in and said, I was told not to exercise. Well, a great message of the nurse said, no, that's not correct. No, you can exercise. You should exercise. You must exercise. So I think that filling that workforce gap is a high priority. I spoke to some colleagues the other day, and they wanted to train the physician up. They wanted to train the medical oncologist up to prescribe exercise. Well, that's never going to work. The amount of training required, the medical oncologists, they need to focus on their main scope of practice, not go off and try to work in something else. You don't, if you're building a house, you don't say, well, we're short of electricians, so let's train the plumber to be an electrician. It just doesn't happen. The plumber's got enough to do. So I think, however, we need to train the oncologists around the importance of exercise oncology as a first-line treatment and as an adjunct treatment as well. So they have an appreciation of that as a referral pathway. But then how do you actually, what are their pathways to be able to refer my patient off to receive high-quality exercise oncology support? So because we know it's a very powerful message. If the oncologist, the urologist, even the general practitioner even says, look, you've got cancer, this is going to be tough. And what's going to make it less tough and perhaps have a better outcome is you need to get exercise medicine. Just that's a 10, 20-second statement. It makes a huge difference to the patient's subsequent behavior in seeking exercise medicine and sticking to it once they get a program or a prescription. So that's a very important also strategy, I believe, as well. The facilities, I think that we're doing more and more to provide exercise in the home. A lot of patients can't afford to go to a fitness facility. The model around about 16, 17 years ago, I proposed a model where we put exercise clinics within hospitals. I'm not so sure it was a great idea. I think that, most of the patients that we see there, they go along for treatment, for chemo, radiation, or whatever. They'll go along to the hospital. They don't like it. And certainly once they're finished, they do not want to go back to that hospital. They can't stand the smell of it, the look of it, the everything. It's just it's the actual trauma of it. So I'm not so sure that was a great idea. We did a lot of work around co-locating exercise clinics within cancer centers. It's a lot of capital outlay. It's a lot of operational outlay. The hospital has to employ exercise physiologists or physiotherapists. They have to set aside floor space. As you know, floor space in a hospital is at an absolute premium. To set aside space to put an exercise clinic in, that's going to be difficult to get past the hospital administrator. So look, I think in some instances it is. I mean, it's highly valuable. We do a lot of work where we have the patients exercising immediately before or during some of their in-hospital treatments. So we have to have some facility for exercise, but the vast majority of exercise medicine needs to be provided to the patient as an outside the hospital or the cancer centre. Most likely it'll be within their home. So how do you actually provide that safely? With having them monitored and supported, and for them to understand that they're being monitored and supported. How do you provide a high fidelity program in the home? You can't say, oh, it's in the home, we don't want to give anything too intense, so we'll just have them doing light weights. Well, light weights doesn't work. Doing low-level resistance training doesn't have any benefit. It has to be moderate to high intensity. And so we need to work out how we can do that. And we're having a lot of success in that area. As I say, because of COVID, we learned a lot from that, how we can provide really high quality exercise medicine in the home.
Yeah, thank you. I think challenges that you were referring are probably transversal to different countries. At least that's what we have here as well, in Portugal and in locations where I've discussed this with colleagues. So we've discussed some of the things that you've published. We touched on position statements of what the state of the art. You have visibility, let's say, into areas that we will only hear from in a few months or years. What excites you most about ongoing research or potential future directions of exercise in oncology?
Gee. Look, I think there's huge potential from what we're learning about how exercise creates endogenous medicine, so medicines from within the body. I think the potential for using that to develop new therapeutics, I think there's considerable potential there. And also how we can develop therapeutics, drugs, which actually facilitate the exercise effect. I think there's huge potential there as well. But we don't understand how exercise suppresses cancer. We don't understand that well enough at the moment. So we need to do more of that research. But once we have that, and how it interacts with the genetics of the patient and the genetics of the cancer, I think there's a huge potential for pharmaceutical development into how you actually make the exercise more powerful. How do you increase the benefit of it? I think too that once we have that, exercise prescription will be far more precise, and so we'll be able to do genetic profiling of the patient. I mean, within the next 3 to 5 years, for $10, you'll be able to completely map the genome of each individual patient, and then from that, you'll be able to determine what is the best exercise in terms of mode, quantity, and intensity, and so become much more precise. And I think that also looking at some of the other markers, a lot of work being done around IGF-1, the impact of insulin, a whole range of other biomarkers, again, to work out the timing and the specifics of how the exercise is implemented. as well. So lots of things to look at.
Thank you. And as we are getting to the end, so if you could share like 3 key messages with healthcare professionals about exercise in oncology, like say some clinicians that are considering, should I train myself in exercise in oncology? Should I consider exploring this field in more depth? What messages would you convey?
Probably the first one is, I think, that really engage with your multidisciplinary team and look at how you can actually bring an clinical exercise physiologist and perhaps a physiotherapist more engaged in the team, particularly looking at opportunities to upskill them specifically in oncology. I think that the opportunities now, particularly after the challenge paper, I think the opportunities in exercise oncology are quite large, and professionals with that expertise and training will be highly sought after. So if you're in university and you're doing an exercise science degree and you're considering the clinical path, I think really consider making that not in cardiac rehab, but perhaps consider making it in exercise oncology as the opportunity there.
Thank you. I agree. And we need many more professionals.
Many more. Yeah. It's I think that in rehab departments in universities, I think that they need to be more open to bringing particular clinical exercise physiologists in. There has been some pushback from physiotherapy to say that this is our domain. We don't have enough physiotherapists. We'll never be able to treat the number of cancer patients. It's overwhelming. So I'd encourage hospital departments to recruit more exercise physiologists to work with the physiotherapists. I talk to physios and I say, what are you worried about? And what, you don't have enough work? And they said, oh no, we're overwhelmed. I said, well, why are you worried about clinical exercise physiologists, providing support services to the patients? So they need to be more open to that. We will never have enough physiotherapists and clinical exercise physiologists to support the burgeoning increase in people with cancer. We're going to have to pull together all resources that we possibly can. And that's what I say, we have to mobilize the commercial health and fitness industry, which is substantial. I mean, it is large in most countries of the world. They have to change the way they operate in some cases. Some of them may have to say, no, we're going to make a conscious decision to move away from the very small percentage of our current market, which is the young, fit and healthy, and perhaps maybe create an environment which is more suitable to look after the clinical population and more welcoming to older people to come in. I think there's huge opportunities there. Anyway, we've gone on. I've talked on. Fantastic. Thank you so much for the opportunity. I've really enjoyed it.
Thank you. And I really enjoyed this too. It was a true pleasure. And I'm sure that we'll be in touch about all these opportunities and research to come and common areas of interest. So thank you so much. I hope you enjoy.
Thank you so much. And I hope we see you in our exercise oncology course perhaps in Germany.
Yes,
or one of our other FitMed exercise oncology courses sometimes in the future.
Thank you.
Fantastic. Thanks.
I'd love to. Thank you.
Ciao, ciao.